Imagine for a moment that your house is a high-tech smart home. It's got everything. Motion sensors, automated locks, maybe even a fire suppression system.
The works.
The works. And the security protocol is designed to be the ultimate protector. It detects an intruder, it seals the doors, calls the authorities. Perfect.
Right. In theory, yes. But biology is, well, it's rarely that perfect.
Right. Because now imagine that whole system is calibrated just a little too sensitively. A neighbor walks by the window, or a gust of wind rattles the mail slot. And instead of ignoring it, the system interprets it as a level 5 threat.
Okay.
It doesn't just lock the door. It floods the basement, cuts the power, blasts a siren that shatters the windows, and then releases tear gas into the living room.
That is a terrifyingly accurate description of what we're talking about today. We're dealing with a defense mechanism that is so potent, so rapid, and so aggressive that if it triggers at the wrong time, the defense itself becomes way more dangerous than the threat it was trying to stop.
It's the body's panic button. We've all seen it or felt it. A bee sting, a sudden rash of hives, or that terrifying moment where a throat starts to swell shut.
And these aren't accidents. They are orchestrated responses.
Orchestrated. I like that word. It's a sequence. And today, we're going to look at the two main conductors of that chaos. We're doing a deep dive into histamine and bradykinin.
And our theme for this exploration is, fittingly, vessels, leakage, and alarm.
Which sounds like a disaster movie title, but it's actually a pretty good summary of emergency medicine.
It really is.
Before we jump into the chemistry of that panic, let's just lay out our sources. Where are we getting this information?
We're synthesizing a couple of heavy hitters. We've got Goodman and Gilman, the chapter on histamine, bradykinin, and their antagonists, which is just incredible for the molecular depth, the real why and how.
That's our mechanistic Bible, and we're pairing that with Katsung.
Yeah, 2 chapters from Katsung, the one on histamine, serotonin, and the ergot alkaloids, and the next one on vasoactive peptides, which is where we find bradykinin.
And Katsung is just so good for that clinical organization, right? How we actually use the drugs.
Absolutely. It scaffolds the whole topic perfectly.
Okay, so the essential disclaimer for everyone listening. We are building a conceptual map today. We're giving you the metaphors, the systems thinking, the scaffolding to hang the details on.
But this is an interpretive synthesis. Let's be really clear about that.
This is not a substitute for the textbooks.
Not at all. If you are prepping for your boards or, planning to treat actual patients, you have to read the chapters. Our job is to make it so that when you do read them, the information clicks into place. We're analyzing the system, not just memorizing drug names.
So with that framework, let's set the stage. What's the mission for this deep dive? What are the key takeaways you should have by the end?
I think we can boil it down to 5 key concepts. First is speed and locality. We need to understand why these molecules work in seconds and why they act locally. They're what we call autocoids, not hormones.
Right, they're not broadcasting to the whole body, at least not usually.
Exactly. Second is the vascular paradox. This is a huge one. How can vasodilation and increased permeability be a brilliant strategy for defense, but a terrible one for, say, maintaining your blood pressure?
The classic trade-off. You're fighting the invader, but potentially killing the host.
That's the heart of it. Third is receptor specificity. We're going to get really clear on the difference between the H1 receptor, your classic allergy alarm, and the H2 receptor, which is mainly busy making stomach acid.
Which explains why an acid blocker doesn't help with hay fever.
Spoiler alert, yes.
Okay.
It's a perfect example. Fourth is sensory spillover.
Okay.
Why do these alarm systems create collateral damage like itch, pain, and that nagging cough?
And finally,
therapeutic restraint. How do our drugs dampen the alarm without just turning off the entire security system?
All right, a fantastic roadmap. So let's start with the headliner, the celebrity of the group, the scout, the sentry. Let's talk about histamine.
Histamine is, a deceptively simple molecule. It's hydrophilic. It's got this imidazole ring. Your body makes it from the amino acid histidine. It just snips off a carboxyl group with an enzyme.
So, simple structure, but the way it's stored is anything but simple. I was reading in Goodman and Gilman, and the thing that struck me is that histamine is not just floating around free in the bloodstream.
No, and that is a critical point. If it were, you'd be in a state of permanent vascular collapse. Your blood pressure would be 0.
So it's an autocoid, a self-remedy. It has to act near where it's released.
Right. So the body has a storage problem. You've got this incredibly potent chemical weapon, and you need to keep it locked up safely inside the cell.
So how does it do that?
Sequestration. Histamine is packed into what I like to call ammunition crates. These are the secretory granules inside mast cells and basophils.
And these granules, they're not just little bags of histamine, are they? They're highly organized structures.
Incredibly organized and dense. Inside the granule, histamine is positively charged. So to pack it in really, really tightly, the cell complexes it with these huge negatively charged macromolecules, usually heparin or chondroitin sulfate.
So it's an ionic bond,
And it has...
an acid-base pairing.
Exactly. It effectively neutralizes the molecule while it's just sitting there in the silo waiting.
The text also mentioned it's stored with ATP. That seems significant.
Oh, huge! ATP is energy. So think about it. The cell packs the weapon with its own power source. It creates a loaded spring.
So when the signal comes to release, it doesn't just trickle out.
It explodes out. It's an active, energy-dependent process, a true degranulation.
Okay, so we have these loaded guns, the mast cells, sitting in the tissues. Where are they stationed? Because location must be everything here.
They're the border guards. You find the highest concentrations of mast cells exactly where the body meets the outside world.
The skin.
The skin, the bronchial lining of the lungs, the mucosa of the gut. They are sitting right there at the frontier, granules packed, monitoring for trouble.
The sentry is at the post, the gun is loaded. So now we need a finger on the trigger. How do we open the crate?
There are two main categories of triggers. The first, and the one we're all familiar with from allergy season, is immunologic release.
This is the specific threat response.
Right. This requires sensitization. The first time you're exposed to, say, ragweed, your body makes IgE antibodies against it.
And those antibodies then go and stick to the surface of the mast cells.
They do. They just sit there waiting. So the next time you breathe in that ragweed pollen, the pollen antigen finds those specific IgE molecules on the mast cell.
Okay.
And here's the key mechanical step. One pollen molecule has to bridge two IgE antibodies. It pulls them together. We call this cross-linking.
It's like turning two keys in a nuclear sub at the same time.
That's a great analogy. That physical cross-linking sends a signal through the membrane. It's a cascade that opens calcium channels. Calcium rushes into the cell.
And that calcium surge is the trigger for the granules to fuse with the cell membrane and just dump their contents.
That's explosive degranulation. And that's your type of hypersensitivity reaction.
Right.
Hay fever, acute hives. It happens in seconds because the ammo was already packed and ready to go.
Okay, but there's another way to pull the trigger, right? And this one seems to cause a lot of confusion in the clinic. The chemical or mechanical release.
Yes. This is really important to distinguish. This does not require IgE. It does not require prior sensitization. It's a direct chemical effect.
The sources call this displacement.
Exactly. There are certain drugs, and the classic examples are morphine, codeine, tubocurin, that are basic amines. Structurally, they're able to get into the mast cell and physically kick histamine off of that heparin binding site we talked about.
They just elbow it out of the crate.
Literally. They displace it from the ionic complex, and once it's free inside the cell, it leaks out.
Okay, so this totally changes how I think about allergies on a patient's chart. If I give a patient morphine and they get itchy or they get flushed, that red man syndrome we sometimes see, that isn't necessarily a true allergy.
It is almost certainly not a true IgE-mediated allergy. We call it a pseudo-allergy. It's dose-dependent and rate-dependent.
Meaning if you give the morphine slower or a smaller dose.
The reaction is much less severe or doesn't happen at all. In a true IgE allergy, even a microscopic amount can trigger a massive systemic explosion. This is just direct chemical displacement.
That is a massive clinical distinction. One is an annoyance, the other is potentially lethal anaphylaxis.
Absolutely. And mechanical release is even simpler. If you just scratch your skin, you are physically breaking open mast cells, you're rupturing the crates. That's why a scratch gets red and puffy.
The histamine is out, the grenade has gone off, now it has to find a target. And this brings us to the receptor landscape.
Right. This is where we have to get into the weeds of the mechanism, because if you don't understand the receptors, you don't understand the drugs. We have four main types, H1 through H4, but H1 and H2 are the titans of pharmacology.
Let's start with H1. You called this the alarm receptor.
It is. The H1 receptor is coupled to a G protein called GQ.
GQ. Okay, for listeners who haven't had biochemistry in a little while, what does GQ actually do?
Think of GQ as the contract and react pathway. When histamine hits H1, the GQ protein activates an enzyme called phospholipase C.
Which then generates IP3 and the DG, the classic cascade.
And IP3 is the key here. It goes to the endoplasmic reticulum, the cell's calcium storage tank, and rips open the calcium stores. The cell just floods with intracellular calcium.
And calcium in muscle cells usually means contraction.
In smooth muscle, yes. So in the bronchi, your airway's H1 activation leads to that calcium spike and the muscle clamps down. Bronchoconstriction.
Which is why asthmatics are so hypersensitive to histamine.
Exactly. Their airways are already twitchy. A little bit of histamine can really shut them down.
But wait, here's the paradox. If calcium causes contraction, why does histamine cause vasodilation? Why do blood vessels open up? Shouldn't they clamp down too?
That is the brilliant part. It's all about location. In the blood vessels, the H1 receptors are not on the smooth muscle cells wrapped around the outside. They're on the endothelium.
The inner lining cells.
The single layer of cells lining the vessel. In those endothelial cells, that same calcium spike stimulates an enzyme called enos endothelial nitric oxide synthase.
Which, as the name implies, makes nitric oxide.
And nitric oxide is a gas, a potent signaling molecule. It diffuses out of that endothelial cell right into the smooth muscle cell next door and tells it to relax.
Wow. So the same H1 receptor causes contraction in one place and relaxation just millimeters away.
It's an indirect relaxation, a beautiful system. H1 contracts airway smooth muscle directly, but it dilates vascular smooth muscle indirectly via nitric oxide.
That explains the redness and the heat. What about the nerves, the itch?
H1 receptors are on sensory nerve endings. Activating them depolarizes the nerve, and your brain interprets that signal as itch and, at higher concentrations, pain.
And in the brain itself?
In the brain, H1 is a major excitatory receptor. It's part of the system that maintains wakefulness.
Which is why blocking it with something like Benadryl knocks you out. You're literally turning off the stay awake button.
Precisely. Now, we can pivot to H2. This is the sustainer receptor. It's coupled to a totally different G protein, Gs.
And G is the stimulatory pathway that makes CAMP.
Right. GS activates an enzyme called adenylocyclase, which pumps out cyclic AMP. In the stomach, that CMP signal is the primary driver for parietal cells to pump acid into the stomach.
So that's the main target for drugs like Zantac or Pepcid.
The major therapeutic target, yes, but H2 is also found on blood vessels.
Okay, so how does it work there?
In vascular smooth muscle, the rise in CAMP directly causes the muscle to relax. But unlike the fast NO-mediated pop from H1, this H2-mediated vasodilation is slower to start and it lasts longer.
So if you have a massive histamine release, like an anaphylaxis, you get a double whammy.
You do. H1 hits the vessels fast and hard via nitric oxide, and then H2 comes in and keeps them open via CAMP.
Which leads to profound, sustained hypotension, a coordinated attack on your blood pressure.
It's a very effective way to drop blood pressure, yes. And there's one other cool thing about H2. It's also on the mast cell itself.
As a feedback loop.
A negative feedback loop. When H2 on the mast cell is activated, it inhibits further histamine release. It's the cell's own little, okay, that's enough signal.
Before we move on, I saw a note about H3 and H4. We usually kind of gloss over them in basic pharmacology, but they have some interesting roles.
They do. H3 is primarily in the brain. It's a presynaptic autoreceptor coupled to G, the inhibitory G protein. Its job is to say, okay, we have enough histamine here in the synapse, stop releasing more.
So another negative feedback loop, but in the CNS.
Exactly. And H4 is the recruiter. It's also inhibitory, gay-coupled, but it's found on immune cells like eosinophils and neutrophils. It's involved in chemotaxis, calling in the reinforcements to the site of inflammation.
A major target for future drugs, I'd imagine.
A huge target for drugs to treat chronic inflammatory or autoimmune diseases.
Okay, so we've got the molecule, the release, and the mechanics. Now let's try to visualize all this in action. Section 2, the visible alarm.
And the classic teaching tool here, and every medical student learns this, is the triple response of Lewis. It was described almost 100 years ago, and it just perfectly illustrates the physiology of histamine in the skin.
Walk us through it. I take a tiny needle, I inject a little bit of histamine into your forearm. What's the very first thing I see?
Phase 1, the red spot. Almost instantly, I mean within seconds, right where the needle went in, you get this small, well-defined red dot.
And that's just the direct effect of histamine hitting those H1 receptors on the local blood vessels, right? The NO-mediated vasodilation.
That's it exactly. Direct local vasodilation.
Simple enough. What happens next? Phase 2.
Phase 2 is the flare. This is where it gets interesting. A diffuse kind of blotchy redness starts to spread irregularly around that initial spot. It feels warm.
But here's the catch. The histamine itself hasn't had time to diffuse that far out yet.
Not at all. The flare spreads much faster than the molecule can travel through the tissue.
So how does the redness spread faster than the chemical?
It's a neural reflex, the axon reflex. The histamine at the injection site stimulates the sensory nerve ending. That's the itch.
Okay.
That electrical signal travels up the nerve axon, but instead of just going straight to the spinal cord, it branches off, and the signal travels back down other branches of that same sensory nerve to neighboring blood vessels.
Whoa, so the nerves are broadcasting the alarm. Hey, we took a hit over here. Open up the supply lines all around the area.
That is a perfect way to put it. The nervous system amplifies and spreads the initial chemical signal. It's a neuroinflammatory loop.
And phase 3.
Phase 3 is the wheel. That original red spot starts to get puffy, it becomes raised, and it turns pale as it gets tense with fluid.
It looks like a mosquito bite.
Because a mosquito bite is this reaction. The swelling is edema. This is the leakage part of our title.
So how does that happen?
The endothelial cells, especially in the tiny postcapillary venules, have H1 receptors. When activated, the cytoskeleton in these cells contracts. The cells literally pull apart from each other like opening the slats on a Venetian blind.
And that creates gaps between the cells.
It exposes the basement membrane and lets fluid and proteins pour out of the bloodstream and into the tissue.
Now, we keep calling this a panic button, but there's a clear purpose here. Why does the body want to leak fluid and proteins into a site of injury?
It's all about battlefield preparation. That fluid carries antibodies, it carries complement proteins. The swelling and slowing of blood flow allows white blood cells to stick to the vessel wall, marginate, and then crawl out through those gaps to fight whatever pathogen is there.
So the inflammation is creating a highway for the immune system.
It's building the highway and delivering the troops.
But when that battlefield prep happens in, say, your larynx,
it's called angioedema. The tissue swells, the airway occludes, and the defense mechanism itself becomes lethal.
Or if that vasodilation happens systemically, all over the body at once.
You get histamine shock. The vessels everywhere dilate, the fluid leaks out of the vasculature into the tissues, your effective blood volume just disappears, your blood pressure crashes. It mimics anaphylaxis because anaphylaxis is largely driven by this exact mechanism on a global scale.
Speaking of a global scale, there's a case study in the source material that is just fascinating. It's a toxicology case, but it perfectly mimics a severe allergic reaction. Scombroid fish poisoning.
Ah, yes, the mahi-mahi flush, a classic.
Paint the scene for us.
Okay, so you're at a nice seaside restaurant. You order the seared tuna, maybe some mahi-mahi or mackerel. It comes out, looks great. You take a bite, and it tastes a little peppery, or maybe a bit of a metallic tang.
That peppery taste is the classic board exam clue, right?
It is the absolute giveaway. But you figure, oh, exotic spices, and you finish the fish.
Okay.
10, maybe 20 minutes later, you're not feeling so great. You are burning up. Your face is beet red. You're sweating. Your heart is pounding out of your chest.
Tachycardia.
Right? You get a splitting headache. You feel nauseous.
And naturally, everyone at the table assumes the worst. He's having a severe allergic reaction to the fish. Call an ambulance.
It looks for all the world like a textbook IgE-mediated anaphylactic reaction. But here's the twist. You've eaten tuna your whole life. You have zero history of allergies.
So what on earth happened?
You've been poisoned by a breakdown in the cold chain. Scombroid fish, that family, including tuna and mackerel, have very high levels of the amino acid histidine in their muscle tissue.
Okay.
If the fish isn't kept properly chilled, certain bacteria start to grow on it. And these bacteria produce an enzyme called histidine decarboxylase.
So they take the histidine in the meat.
And they convert it into histamine. That tuna steak on your plate is essentially a massive oral dose of pure histamine.
You are literally overdosing on the mediator itself.
Exactly. It completely overwhelms the enzymes in your gut that normally break down any histamine in food. It gets absorbed, floods your bloodstream, hits all your H1 and H2 receptors systemically, and causes the shock-like syndrome.
And the proof that it's histamine is in the treatment.
The proof is in the pudding. We treat it with H1 and H2 antagonist antihistamines, and it works beautifully. Because it is a histamine problem, it just came from the plate, not from your own mast cells.
That is wild. So, pro tip, if your tuna tastes like pepper, send it back.
Immediately send it back.
Okay, that is a fantastic deep dive on the Scout, the rapid responder. Now let's pivot to the other major player in this drama, the slow mover with the heavy punch, bradykinin.
Bradykinin is a completely different beast. The name itself tells you that. Brady for slow, and kinin from the Greek canon, to move.
So it causes slow movement.
Right. When early researchers put this substance on isolated gut tissue, it caused a contraction, just like histamine. But it developed much, much more slowly.
So if histamine is the explosion, bradykinin is more like a lava flow.
That's a great analogy, but don't let slow fool you into thinking it's weak. It is incredibly potent.
How potent?
On a molar basis, bradykinin is about 10 times more potent as a vasodilator than histamine is.
10 times. That's a huge difference. Now, unlike histamine, bradykinin isn't sitting in a crate waiting for a trigger, is it?
No, there's no storage. Bradykinin is synthesized on demand from precursors already circulating in the blood. It's the product of an enzymatic cascade.
The sources outline this pretty complex cascade, but let's just strip it down to the essentials for now.
Okay, so floating in your plasma all the time is a protein called high molecular weight kininogen, or HMW kininogen. That's the raw material.
The inactive precursor.
Right. Then you have an enzyme, a pair of molecular scissors, called plasma kallikrein.
Kallikrein.
Normally, kallikrein is also inactive, but when you have tissue damage, or when the clotting cascade gets activated, specifically factor 12, that activates kallikrein.
So injury triggers clotting, which in turn triggers this kallikrein enzyme.
Exactly. The activated kallikrein then finds the kininogen, snips off a small piece of it, and that small piece is the active 9-amino acid peptide, bradykinin.
So injury leads to clotting, which leads to bradykinin. It's all interconnected.
It's a beautifully integrated system of damage control and inflammation.
Okay, now here is where we get to what I think is the biggest aha moment in this entire topic. The link between bradykinin and some of the most common heart medications on the planet. I'm talking about the ACE connection.
This is the concept that ties everything together. Pharmacology, physiology, pathology. It's crucial. So bradykinin is made on demand, but it also has a very, very short half-life.
Seconds.
Just a few seconds before it gets chewed up and inactivated by enzymes in the lung and blood. The primary enzyme that does this is called kinase II.
Kinase II.
But we almost never call it that in the clinic, because it turns out that kinase II has another very famous job. It is the exact same molecule as angiotensin-converting enzyme, ACE.
The same AC that converts angiotensin, the Rs, into angiotensin II.
The very same enzyme. And just stop and appreciate the elegance of this system from a blood pressure perspective. What does ACE do? On one hand, it creates angiotensin II.
Which is one of the body's most potent vasoconstrictors.
Right.
Clamps vessels down, raises blood pressure.
Right. And on the other hand, what does ACE do? It destroys bradykinin.
Which is one of the body's most potent vasodilators.
So ACE is a master switch. It creates the clamper and at the same time destroys the opener. The net effect is that it pushes the entire system towards vasoconstriction and higher blood pressure.
It's a double agent working for hypertension.
That's a great way to put it. So now let's think about what happens when we give a patient an ACE inhibitor, something like lisinopril or enalapril.
Okay, so we block the enzyme. Step one, we stop making angiotensin II. That means vessels relax, blood pressure goes down. That's the intended effect.
But what's step two? What else happens when you block that enzyme?
You stop destroying bradykinin.
Bingo. And that's the key. Bradykinin levels start to rise. And since bradykinin is a powerful vasodilator, this actually helps lower the blood pressure even more. A significant part of the therapeutic benefit of ACE inhibitors comes from this accumulation of bradykinin.
But as always, there is no free lunch in physiology.
Never. Because bradykinin isn't just a vasodilator, it's a powerful inflammatory mediator. It causes that vascular leakage, and importantly, it irritates sensory nerves.
Which brings us perfectly to Section 4, clinical integration. Let's talk about the infamous ACE inhibitor cough.
This is the classic board question, but it's also a daily reality in primary care. You start a patient on lisinopril for their hypertension, their blood pressure looks great, but 2 or 3 weeks later they come back and they are complaining of this dry, tickly, persistent, maddening cough.
It's not an infection. It's not post-nasal drip. They just can't stop this little tickle in their throat.
It's the bradykinin. By blocking ACE, especially in the lungs where ACE is highly concentrated, you've allowed bradykinin to accumulate. It directly irritates the sensory C fibers in the bronchial tree.
So it's creating a false sensation of irritation that triggers the cough reflex.
Exactly. And you can't treat it with cough syrup because the trigger is chemical, not mechanical. The only solution is to stop the drug.
And you switch them to an ARB, an angiotensin receptor blocker, which works downstream and doesn't affect bradykinin levels.
Correct. The cough goes away.
But the cough, while annoying, is just the tip of the iceberg. There's a much rarer, much more dangerous side effect of this bradykinin accumulation.
Angioedema. In some patients, and we see this more often in patients of African descent, the bradykinin levels don't just rise a little, they spike dangerously high.
And the result is massive vascular leakage.
Massive. The vessels in the face, the lips, the tongue, and the larynx become incredibly leaky.
You're back to the airway closing shut.
It is a true medical emergency. The lips can swell to 3 times their normal size. The tongue can protrude from the mouth. And because this is mediated by bradykinin, not by histamine.
The standard anaphylaxis treatments, epinephrine, antihistamines, steroids, they don't work as well.
They work very poorly. Epinephrine is still used because it's a physiologic antagonist and can help vasoconstrict, but it is not the magic bullet. It is in a histamine-driven reaction. This is a kinin storm.
Which is a perfect segue into the genetic version of this nightmare, hereditary angioedema, or HAE.
HAE is a fascinating and devastating disease that really highlights the importance of biological breaks. In a healthy person, we have an inhibitor protein circulating in our blood called C1 esterase inhibitor.
C1 inhibitor.
Its main job in this context is to keep that kallikrein enzyme in check. It's a brake. It prevents the system from just randomly chopping up kininogen and making bradykinin when there's no real injury.
It's the safety catch on the gun.
Perfect analogy. People with HAE are born with a deficiency in this C1 inhibitor. They're missing the safety catch.
So their kallikrein can just run wild.
With minor stress, or even spontaneously, their kallikrein goes into overdrive. It produces massive, uncontrolled surges of bradykinin.
And what are the symptoms?
Recurrent, unpredictable, and often excruciating episodes of swelling. It can happen in the hands or face, but a classic presentation is in the wall of the gut.
So they present with severe abdominal pain.
Severe cramping abdominal pain that mimics a surgical emergency. And tragically, these patients are often misdiagnosed for years. They're told they have allergies or irritable bowel syndrome. And if you treat their acute attack with antihistamines and steroids, absolutely nothing happens.
Because, once again, histamine isn't invited to this party. It's a pure bradykinin problem.
A pure kinin problem.
So how do we treat it? We have to target the kinin system directly.
And we have some incredible targeted therapies now. One is a drug called icatibant.
And that one targets the receptor, right?
It does. Let's quickly clarify the bradykinin receptors. There are 2 main ones, B1 and B2.
Okay.
The B2 receptor is the peacetime receptor. It's constitutive, meaning it's always there on your cells in normal tissue. It mediates most of the acute effects we've talked about, the vasodilation, the edema, the acute pain of a burn.
So icatibant blocks B2. It plugs the lock.
It is a specific B2 receptor antagonist. It sits on the receptor and stops the flood of bradykinin from being able to activate it.
And there's another drug, ecallantide.
Ecallantide works upstream. It's an inhibitor of the plasma kallikrein itself. It binds to the scissors and stops them from ever cutting the kininogen in the first place.
Stopping production at the source.
Exactly. It's precision medicine, and it's life-saving for these patients.
You mentioned B2 is the peacetime receptor. What's the other one? B1?
The B1 receptor is the wartime receptor. It is inducible.
Meaning it's not normally there.
It's there at very low levels or not at all in healthy tissue. But if you have chronic inflammation, a long-term injury, or high levels of cytokines like IL-1 and TNF-alpha, the body upregulates the B1 receptor. It builds more of them.
It's reinforcing the front lines for a long siege.
That's it, exactly. And the B1 receptor is thought to mediate chronic pain and chronic inflammation. It's the body increasing its sensitivity to pain signals because it's in a long-term state of alert.
Fascinating.
Yes.
So B2 helps you pull your hand from a hot stove, but B1 is what makes the burn hurt for the next week.
That is a brilliant way to think about it, yes.
We have covered the mediators, the alarm systems, and the diseases of excess. Now let's turn to the medicine cabinet. Section 5. Pharmacology of antihistamines.
Or, as the pharmacologists listening are probably shouting at their speakers, the pharmacology of H1 inverse agonists.
Okay, let's explain that distinction. We all call them H1 blockers or antihistamines. But Katzung and Goodman and Gilman are both very specific about this. Why aren't they just blockers?
It's a subtle but really important concept. A classic blocker or neutral antagonist just sits in the receptor and does nothing. It's inert. It just prevents the real agonist histamine from binding.
Okay.
But the H1 receptor has what we call constitutive activity.
It hums on its own, even without histamine around.
Exactly. Even with no histamine present, a certain small percentage of H1 receptors are just spontaneously flickering into the active state. It's like a car that has a slightly high idle.
So a simple blocker would just prevent you from stepping on the gas, but the car would still be idling?
That's the idea. But an inverse agonist, which is what all our modern antihistamines actually are, does more. It binds to the receptor and actively stabilizes it in the inactive conformation.
So it doesn't just block the gas pedal, it reaches in and turns the engine off completely.
It reduces the activity below that baseline idle. It quiets the whole system down.
Okay, that makes perfect sense. Now, within this class, we have the great divide. First generation versus second generation. The shotgun versus the sniper.
The first-generation drugs are the old guard. Diphenhydramine Benadryl, chlorpheniramine, promethazine. Their defining feature is that they are highly lipophilic.
They low fat, which means they can easily cross cell membranes, including the one that matters most for side effects, the blood-brain barrier.
Correct. And once they get into the brain, they find those H1 receptors that act as the wakefulness switch, and they inverse agonist them into the off position, hence profound sedation.
But they don't just hit H1, do they? They're famously dirty drugs.
Very dirty. They're pharmacologically promiscuous. They also block muscarinic acetylcholine receptors.
Giving you those classic anticholinergic side effects.
Dry mouth, blurred vision, urinary retention, constipation, the whole can't see, can't pee, can't spit, can't.
Right. But that antimuscarinic effect is actually useful for something like motion sickness, isn't it?
It is. Promethazine is a fantastic anti-nausea drug precisely because of that effect on the vestibular system. They also block alpha-adrenergic receptors, which can cause orthostatic hypotension.
Dizziness when you stand up.
And what a lot of people don't know is that they have significant sodium channel blocking effects.
Like a local anesthetic. Like lidocaine.
Exactly like lidocaine. In a pinch, if you have a patient with a true allergy to all conventional local anesthetics, you can actually inject diphenhydramine to numb up a laceration for stitches. It stings, but it works.
I had no idea. So Benadryl is a sedative, an anti-nausea drug, a local anesthetic, and an allergy med, all in one very messy package.
And that messiness is exactly why we developed the second generation. Loratadine, Claritin, cetirizine, Zyrtec, fexofenadine, Allegra.
The non-sedating antihistamines.
The goal was specificity and keeping them out of the brain. They are much less lipophilic, so they have a harder time crossing the blood-brain barrier to begin with. But there's a really cool extra mechanism at play, especially with fexofenadine,
The pump.
the P-glycoprotein pump. This is an efflux transporter. It's a protein in the blood-brain barrier that acts like a bouncer at a club.
Okay.
Its job is to recognize foreign molecules, grab them, and actively throw them back out into the blood.
So even if some fexofenadine molecules manage to sneak into the brain.
The P-glycoprotein pump grabs them and ejects them. It's not that the drug can't bind to brain H1 receptors. It's that it's physically evicted from the CNS before it gets a chance to.
That is brilliant drug design.
It's a fantastic example of using physiology to our advantage.
And what about the H2 antagonists, just to complete the picture?
Cimetidine, ranitidine, famotidine, they are highly selective for the H2 receptor. They are brilliant at inhibiting gastric acid secretion. The key takeaway for us today is that their selectivity proves the receptor subtype theory. They do absolutely nothing for the itch or bronchospasm of an allergic reaction.
Zantac won't clear your sinuses.
Not even a little bit.
Okay, we have to wrap this up with the most critical clinical scenario of all, anaphylaxis. There's a huge trap that young doctors, paramedics, and first responders can fall into.
The Benadryl trap.
You see someone who just ate a peanut, their face is swelling, they're wheezing, they're breaking out in hives, and the immediate instinct is allergy, get the antihistamine.
And that instinct, while understandable, is incredibly dangerous. Antihistamines are too slow and they are far too specific.
What do you mean?
Anaphylaxis is a systemic chemical storm. You have a massive release of histamine, yes, but you also have leukotrienes, prostaglandins, bradykinin, platelet activating factor. It is a soup of vasoactive bronchoconstricting mediators.
And blocking just the H1 receptor is like trying to stop a tidal wave with a single sandbag.
It's completely inadequate. It might help with the itch and hives later on, but it will not stop the throat from closing, and it will not stop the blood pressure from crashing to zero.
So the drug of choice, the only drug that matters in that moment, is epinephrine.
Epinephrine, epinephrine, epinephrine. Because it is a physiological antagonist, this is such a key concept. A pharmacologic antagonist, like Benadryl, just blocks one receptor. A physiological antagonist, like epi, doesn't care about the receptors. It activates a counter system.
It fights fire with water.
It hits alpha-1 receptors to clamp those dilated blood vessels shut, which raises blood pressure and reduces the swelling. It hits beta-2 receptors to blast the airways open. It hits beta-1 to stimulate the heart. It physically reverses the physiological collapse, regardless of which chemical mediators caused it.
So in anaphylaxis, Benadryl is, at best, a sidekick. Epinephrine is the hero.
Epinephrine is the only thing that matters in the first 5 minutes. Everything else is just managing the symptoms after the patient is saved.
We have covered a massive amount of ground today. From the explosive granules in the mast cell to the slow, painful creep of bradykinin. From the triple response in the skin to the deadly swelling of angioedema.
It's a complex and interconnected system, but I think the themes are pretty consistent.
Let's try to synthesize it. What are the big final takeaways?
Histamine. It's the sentry. It's prepackaged in granules, released explosively by IgE or direct injury. It hits H1 for rapid vasodilation and bronchoconstriction, and H2 for gastric acid and more sustained vasodilation.
And bradykinin, the painful vasodilator. It's not stored. It's made on demand by the kallikrein cascade.
Yep.
Crucially, it's destroyed by ACE. So when we block ACE with inhibitors, bradykinin accumulates, leading to cough and angioedema.
And finally, our pharmacology. We use inverse agonists to stabilize the H1 receptor and quiet the system. In a true emergency, we use a physiological antagonist like epinephrine to override the entire collapse. And for rare kinin-driven diseases, we have incredibly specific drugs that can block the receptor or the production pathway.
I want to leave our listeners with that provocative thought we touched on right at the beginning. That evolutionary trade-off.
Right. Why does the body have a defense mechanism that is so powerful it can kill the very person it's trying to protect?
It really does seem like a massive design flaw. A peanut shouldn't be able to kill you.
It seems that way now. But you have to think about the environment we evolved in. For most of human history, without antibiotics or sterile surgery, the single biggest threat to your life was overwhelming infection from a wound or a parasite.
So the body needed a system that could react instantly, violently, and locally to wall off an infection or flush out a parasite from the gut.
It prioritized potency and speed over safety. Evolution would rather you have 100 false alarms, even dangerous ones like anaphylaxis, than miss the single lethal infection that would have killed you for sure. It accepts the risk of the alarm to guarantee the security of the fortress.
But in modern medicine, our job is often to save the host from their own hypervigilant defense system.
Precisely. We are the moderators of the panic. We come in to say, okay, body, thank you for your service, but the peanut is not a parasitic worm. You can stand down.
A perfect place to end. Thank you so much for this deep dive. To everyone listening, your mission is clear. Go back and read Katsung's chapters on histamines and vasoactive peptides and the histamine and bradykinin chapter in Goodman and Gilman. Look at the diagrams. See the cascades.
Use this conversation as your map, your conceptual framework, but you still have to walk the territory yourself.
Until next time, keep learning.
And stay curious.